Hi, everyone. Welcome to our What's New in Addiction Nursing series with the BCCSU. My name is Nicole Cowan. I'm the Interim Nursing Fellowship Director with the program, and I'm also a clinical educator with Vancouver's Withdrawal Management Services. And I'd like to introduce you to our presenter today, Simran Riarh. So Simran is a registered nurse and currently with the Addiction Nursing Fellowship Program with the BCCSU. She's currently employed as a mental health and substance use regional substance use clinical nurse educator with Fraser Health. Her past work experience includes working in Fraser Health inpatient detox withdrawal management centers, as well as Surrey's rapid access addiction clinics. And she's got a wonderful presentation prepared for us today on community managed alcohol programs and the COVID-19 response. Thank you so much, Simran.
Thank you, Nicole. So as Nicole mentioned, what we'll be talking about today is the community managed alcohol programs and the COVID-19 response. So really we're looking at how MAP programs shifted into a COVID-19 response for the vulnerable populations. So I just want to start with a quick land acknowledgement. So I respectfully acknowledge that I'm a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh Nation. I also do not have any conflicts of interest. Okay, so looking at our outline today, so what we're going to talk about is a little bit about the background and where managed alcohol programs started. Then we'll look at the risks and harms of high-risk drinking and the role that COVID-19 played alongside of that. Next, we'll look into what the evidence for community-managed alcohol programs say. Are they actually beneficial for individuals? Do they actually make a difference on the healthcare system? Then we'll take a look at some of the different service delivery models and looking at what it takes to start up a managed alcohol program, and evaluating where some of the managed alcohol programs are currently. And then we'll go over Fraser Health's managed alcohol program, as this was one program that was opened due to COVID-19. I wanted to start off with acknowledging, just to ensure everyone knows about being diagnosed with an alcohol use disorder. So in order to be started on managed alcohol program, it usually requires you to have a moderate to severe, mostly a severe alcohol use disorder. So being diagnosed with a severe alcohol use disorder would mean that you are eligible for at least 6 of these criteria apply to yourself or the client or the patient. So when a physician is starting to do the intake for a managed alcohol program, they'll go through this during their assessment with the client or individual to see if they meet the needs of being started on a managed alcohol program. So managed alcohol programs were created as options for individuals that were impacted by the harms of high-risk drinking. Some of the harms that were intended to decrease with managed alcohol programs are having a severe alcohol use disorder, so the DSM criteria of a score of higher than 6 to bring that down lower. Drinking in unsafe settings, so that could be anything of outside in public areas, parks, which can increase the risk of violence and assault. Non-beverage alcohol use, so that can be rubbing alcohol, mouthwash, or the alcohol-based hand sanitizers. This can also be due to socioeconomic factors that may affect purchasing ability of alcohol. Unsafe drinking patterns, so binge drinking. So in the context of COVID, loss of income from panhandling, closure of bottle depots, and restrictions using cash at liquor stores can lead to binge drinking. Uninterested in reducing or being abstinent from alcohol. Barriers to reducing drinking or abstinence. So homelessness plays a factor, fear of stigma, mental health diagnosis may all play a factor. Withdrawal, so reduced access to services, being physically unwell and not being able to get medical treatment. Violence, we're looking at decreasing the number of interactions with police and the impacts resulting from related stigma that can also lead to incarceration, and harms to physical self, so unintentional injuries from falls, from seizures or withdrawals, or injuries from violence as well. Majority of these harms can lead to emergency room visits, which can be quite costly. We'll be discussing the impact MAP has on the healthcare system later in this presentation. So MAPs have actually been operating in Canada for over 20 years. Scene House is the largest and one of the oldest shelters serving homeless men in Toronto. Scene House dates back to 1931 when it was opened to serve a growing number of unemployable men during the Great Depression. As with many cities, Toronto did not have shelters or supportive housing that allowed continued alcohol use. Most of the managed alcohol programs, including Scene House, were created as a way to address service use barriers related to alcohol use and protect this population from the harms, including severe injury and death, associated with consuming alcohol in street-based settings. It was established as a result of a public inquiry into the freezing deaths of 3 men who were homeless and whose drinking had prevented them from seeking medical help. Scene House has 581 beds at its George Street location and serves thousands of individuals each year in various programs, including harm reduction programs, and refers men to other related programs at other sites if needed. Now looking at what is considered high-risk drinking, what is a standard drink? So as we can see on this slide, it talks about the amount of alcohol in what is considered a drink. So heavy drinking is a measure of males having 4 or more drinks and females having 3 or more drinks. So again, this is just to keep in mind. So when our clients or any individual says they just have a drink, it's also we need to double check with these guidelines of what a drink actually means. So they may think a drink is their 24-ounce bottle, whereas what we're looking at is actually 12 ounces of beer or 5 ounces of wine is considered a drink. Alcohol is by far the most common drug used by Canadians. At least 20% of drinkers consume above Canada's low-risk alcohol drinking guidelines. In Canada, there were around 77,000 hospitalizations entirely caused by alcohol in a study in 2015 to 2016, compared to 75,000 hospitalizations for heart attacks in the same year. So as we can see, alcohol use related hospitalizations are quite high in comparison to other medical treatments. The most recent control and scale of alcohol beverages reports show that in the same study of 2015 to 2016, individuals 15 years of age and over drank an average of 8.2 liters of pure alcohol a year. So this is just looking at some of the stats of who's drinking and the importance of the variations in the total recorded per capita. So just taking a quick look at just our 2 graphs, what this is talking about is a low risk drinking guidelines. And this one up here is just breaking up each province and looking at the hospitalizations that were caused by alcohol. The low-risk alcohol drinking guidelines in 2015, also among the general population, so above 15, who consumed alcohol in the past 12 months, looked at a study. So 20% exceeded the low-risk drinking guidelines for chronic effects. That is, they exceeded the guideline of no more than 10 drinks a week for women and no more than 2 drinks a day most days, and 15 drinks a week for men with no more than 3 drinks a day most days. In the same period, 15.4% exceeded the low-risk drinking guidelines for acute effects. Canadian men are more likely than women to exceed the low-risk drinking guidelines for both type of effects. The guidelines were exceeded by young adults, so aged 18-19 to 24, at higher rates for both chronic and acute harms, and compared to among underage drinkers, which was just 11.5. The adults over the age of 25, the harms were at 19.4. So it just puts in a little bit of a perspective of how now we're having underage drinking as well becoming more of an alarming concern. What we look at here is just alcohol, again, being one of the top substances that's being used by Canadians. So this is from 2015. So 76.9% of the general population, so 15 and over, reported consuming alcohol in the last year. As we can see, alcohol consumption is used more than cannabis or other substance uses as well. On March 11, 2020, the World Health Organization declared COVID-19 caused by a novel coronavirus a pandemic, citing concern over alarming levels of spread and severity across the globe. To mitigate these risks and support individuals to follow public health directives such as physical distancing, healthcare providers and other community support workers have been regularly screening their patients and their clients for high-risk alcohol use and developing alcohol use plans for these clients who are at higher risks of serious complications related to alcohol withdrawal. Managed alcohol programs in the context of COVID-19 pandemic were to address concerns for the vulnerable population, so such as reduced access to alcohol, so the liquor stores closing early, liquor stores not accepting cash, or not being able to go to the liquor store because they need to isolate. There was a concern about the disruption of alcohol supply. Some individuals would pool money together for their alcohol supply. However, with physical distancing and needing to isolate, they were not always around the same group of individuals. There's also concerns of comorbid health conditions, and just knowing that all of these barriers and not having access to alcohol could actually lead to life-threatening withdrawal. So alcohol withdrawal risks. So managed alcohol programs prevent alcohol withdrawal. Why is this important? Researchers have looked into that with each withdrawal-induced episode of CNS hyperexcitability may severe as a stimulant that supports a kindling process. What is a kindling process and why is this important? So it's basically saying that every time your brain experiences withdrawal, your risk of even worse withdrawal the next time increases. So this is just going to show that we don't want people going through a number of withdrawal periods. However, as we can see with some limited supply to alcohol or barriers because of the COVID-19 pandemic, this was a concern because a lot of people, for different reasons, especially working with just a vulnerable populations group, we can see how easily they could be going into withdrawal because their supply to alcohol had barriers for whichever reason. The other thing that we want to look at is preventing alcohol withdrawal will also prevent withdrawal seizures. So withdrawal seizures are generally tonic-clonic convulsions. They're usually either singular or in a brief flurry of seizures over a short period of time, and usually can occur within 12 to 48 hours after the last drink. So as you can see, someone that is binge drinking can be at an increased risk for withdrawal and withdrawal seizures because they're consuming alcohol for a period of time and then they're abstinent for a period of time. So for the vulnerable populations, this can be serious and life-threatening, especially if they're drinking alcohol alone, not connected with services, and binge drinking, when they are in the period of abstinence, they'll go into withdrawal and most likely not seek medical attention. Therefore, they're at a risk of having a seizure and no one being around to support or be able to provide or connect them to medical treatment. We discussed later in the presentation how starting a managed alcohol program in shelters will also help build connections for these individuals and what kind of supports managed alcohol programs actually provide individuals. Now we'll just take a quick look at a few studies. So Shelter House Centers in Thunder Bay, Ontario is a 15-bed mixed gender map that was established in March 2012 in response to the needs of people in the community with severe and chronic alcohol use problems, many of whom have a long histories of homelessness, public intoxication, and regularly consume non-beverage alcohol. Managed alcohol programs provide controlled access to alcohol, usually alongside accommodation, meals, and other supports. The objectives of reducing harm from alcohol use and improving overall quality of life for unstably housed individuals experiencing repeated and severe alcohol-related problems. Reductions of alcohol consumption was not identified as the main goal of this program. However, it was to see if they can get a switch from the use of non-beverage alcohol to beverage alcohol. That was highly encouraged. A small pilot evaluation was conducted in order to establish whether entry into the managed alcohol program was associated with significant improvements in health and well-being and reduction in harms, as indicated by decreased use of emergency, hospitals, police services, as well as less hazardous patterns of alcohol use. 18 managed alcohol participants and 20 control participants were assessed as alcohol dependent, with most of them using non-beverage alcohol. The quantitative and qualitative findings of this pilot study suggest that managed alcohol program participants were associated with a number of positive outcomes, including 41% fewer police contacts, 33% fewer police contacts leading to custody time, fewer detox admissions, 32% fewer hospital admissions, and 47% just fewer emergency room presentations, and decreases in some alcohol-related harms, including the decrease in non-beverage alcohol use, harms in home life, legal issues, and withdrawal seizures. There were reductions in nearly all available liver function tests as well after a participant was on the managed alcohol program. These encouraging trends were being investigated and looked into a larger study. In some cases, non-beverage alcohol is relatively low cost and readily available. So dental mouthwash, for example, Listerine, has 26.9% alcohol and are not thought to pose serious risks unless consumed at very high doses. However, this is more likely to occur among unstably housed and severely alcohol-dependent populations. So some of the reasons that people are going to the non-beverage alcohol use is because of the cost and the fact that it's readily available. This just shows some of the alcohol-related harms experienced in the past month. So just from the study that I had mentioned, as we can see, there is a decrease in the managed alcohol participants in every aspect. So home life, legal, housing, as well as seizures. Okay, so now we'll look at a local Vancouver study. So this study, it happened in Vancouver, downtown Eastside. So although our definition of illicit drinking includes drinking beverage alcohol in stigmatized ways, so public drinking or people that are homeless, participants in this research were restricted to people who had identified as at least occasionally drinking non-beverage alcohol. restricting the inclusion criteria to people who have consumed non-beverage alcohol, although it may not be their drug alcohol of choice, was done to encourage participation by highly marginalized street-involved drinkers. So they really wanted to involve just homeless population as well as the ones that are drinking in public in hazardous situations. The predominant ethnicities were white and indigenous. Ages appeared to range from 20s to 50s. Participants identified as living in single-room occupancy hotels, supportive social housing, and homelessness shelters, or sleeping outside. Most indicated that they were receiving social income assistance through welfare or disability payments. Managed alcohol programs are harm reduction interventions, as we talked about, and they aim to reduce the harms of alcohol use, poverty, as well as homelessness. Managed alcohol programs typically provide accommodation, so they're either in the housing that we just mentioned, health and social supports alongside regular administered sources of beveraged alcohol to stabilize their drinking patterns and replace the use of non-beveraged alcohol. So just looking at what some of the benefits of MAP from this study came out to be is that current harm reduction strategies, so drinking in groups versus drinking alone, this is a balancing act between the risks of being alone and the risks of being in group. One of the quotes from the participant said, even if it's somebody that you don't know, if they have the shakes, you should share. The person is suggesting this says that what goes around comes around. Additionally, participants describe using chip-ins, meaning pooling money together to purchase a bottle of alcohol. So really all you can see there is that they're working together to avoid withdrawal. Participants continue to describe throughout the study how avoiding the harms of alcohol withdrawal primarily through their social networks, in which sharing alcohol played an important role. The reason I bold social networks here is we're going to talk about how managed alcohol programs also string some of these social networks. Limiting the amount or pace of alcohol consumption, so strategies illicit drinkers use to reduce the amount they drink, included purchasing smaller volumes, drinking with friends who drink less, and mixing alcohol with non-alcoholic beverages. They're looking after one another. Illicit drinkers particularly took overly intoxicated people somewhere safe to see if they needed to get medications to manage their withdrawal symptoms. Some participants had mentioned using physician-prescribed or street-prescribed medications when experiencing withdrawal. Managed alcohol programs proposed harm reduction strategies, including one important one being a safe space. So a place where illicit drinkers would be protected from crimes, from the stigma. Managed alcohol programs also have a non-residential managed alcohol program with strong connections to other services. So connecting them to detox and housing. There's peer-based service programs, and where illicit drinkers would be decision makers were seen as more this was seen as more likely to meet the community's needs. There was also education being provided, so of illicit drinkers by illicit drinkers, for healthcare professionals by illicit drinkers again, and of illicit drinkers by topic experts. So as we can see in this study, there was a lot of benefits that came out of managed alcohol program, as well as we were able to learn a lot through the participants, as well as being able to have them share their experiences of what it's actually like to be living on the street and going through alcohol withdrawal or not having enough alcohol to last you until you have the money to go buy some more. This is now going and just looking at a few different studies and articles, which this is what the evidence of MAP benefits are. So although treatment and with detox and abstinence is the best option from a health perspective, the likelihood of rehabilitation among people both with an alcohol use disorder and homelessness is low. So what we look at here is reducing alcohol-related harms. So managed alcohol programs were able to reduce withdrawal, seizures, unintentional injuries, which included minor to significant injuries from bruises and bumps to bleeding to death. Participants were particularly concerned about choking. So if they were intoxicated and they were able, there's a risk of them being choking on their own vomit. Reduced total alcohol consumption, so the number of drinks were lower or the amounts that they used were lower each time. Improve mental health, so harms to mental health, particular depression and isolation. So again, this is a social network piece that came into mind because illicit drinkers were seen at particularly high risk of suicide yes, high risk of suicide. We wanted to get engagement with the healthcare system, so participants reported that they would be turned away from healthcare systems when intoxicated. The managed alcohol programs improved physical health, so participants recognized the negative effects of illicit drinking on their liver and memory. But many of them had questions and learned more about withdrawal seizures, delirium tremens, and shakes. The biggest thing was also improving social function. So in Fraser Health, we have seen this improve as the managed alcohol program has lounge chairs and a private little area set up. So the managed alcohol participants have a place to sit together. Improve housing. So as we mentioned, they're either in shelters, hotels, or some sort of housing program that's attached to the managed alcohol program. And reduce the utilization of acute services. So overall, there's less ER visits with intoxication and withdrawal being the chief complaint. Transitioning to other appropriate services, we were able to increase the number of client engagements. So increasing showing up to appointments, reducing no-shows or not being able to connect with individuals, prevent complications from severe alcohol use disorder, and either maintain or reduce alcohol intake to prevent withdrawal. And then also eliminate or reduce non-beverage alcohol use, and also in the context of COVID-19 was to reduce the risk or prevent COVID-19 infection and transmission in the communities. This is just a bit of an update on the managed alcohol programs in Canada from March. So I am a part of a call where everyone shares where they are with their programs. So in Halifax's managed alcohol program started in COVID. It's an outreach model, and they started to do primary care, which included blood work, treat chronic insomnia, and nutrition plans. Yellowknife also started in COVID, but they're in the process of converting from a COVID-based managed alcohol program to something sustainable long-term. They're saying with the managed alcohol program in terms of COVID, they're isolating and keeping people in one place, which may or may not be their preference. So they're trying to see how they can sustain this program long-term. We'll review a case study shortly to look at how managed alcohol participant has actually significantly decreased ER visits. But this is just a slide I wanted to show to compare ER visit cost versus the cost of alcohol. So an emergency room visit for a Canadian citizen without medical service plan is about $322. It comes up to being around $750 when you include the doctor's fee. So this is not including lab work or testing. However, if we have a client who is currently on having 5 drinks a day, the daily cost for that client is $7.10. So if they're spending the day in the emergency room, we can see how we're close to being in the thousands versus spending $7.10 on this individual on a managed alcohol program. Just looking at the service models, how to actually start a map. So all of this stuff sounds great, but you might be wondering now, what does it actually take to start a map? So there's a lot of planning that goes into it. You need to actually be able to acknowledge and address some of the other social determinants of health of chronic drinkers. We want to incorporate harm reduction and trauma and violence-informed care as much as we can. We want to provide holistic and comprehensive care and referrals where needed, involve family and social contacts in care planning with these individuals, as well as include people with lived experience in the design and the provision of this program. So there's a few different models as well. Community-led harm reduction model, which is primarily run by harm reduction staff and people with lived experiences, or you can have a clinician-initiated team-based model. So that'll include nurses, physicians, MHSU, or harm reduction staff, and people with lived experience. So depending on the staffing, it depends on the model of the managed alcohol program, but it's important to know the hours as well. So usually administration of alcohol may vary from 1 to 2 drinks a day to up to 12 times a day. So sometimes if you have staff just during the daytimes, like 8 to 4, we need to see what we have available for the clients in the evening. And storage on site, so extra supply must be kept in a locked storage unit. For example, the manager's office or in a staff only access area. And the fridge with the alcohol that's being used daily needs to have a lock on it. So alcohol must be treated the same way as medication storage or money management system. Looking at the funding, so it can be health authority funded, private, client contributions. So there's a few different ways to get funding. Procurement, so obtaining and purchasing alcohol, again, it depends on the organization. You can buy it from a liquor store, a brewery, pharmacies. Pharmacies are most likely just involved when it's acute care. You need to look into the delivery. So delivery procedures may not apply if the alcohol storage is not kept on site, or there might need to be a plan of doing frequent pickups. So someone from the team going to the liquor store. Again, you also need to be able to decide how often to get the deliveries or pickups. So you need to kind of look at your order, see how much alcohol is being used a day by the clients, how often is this supply going to last you, because you don't want to be running out. Just looking at care planning, so other things to consider is when to contact a physician. Some of the key points we want staff to know: when to actually reach out for help, especially after hours. So if they're concerned about intoxication, someone is really unsteady on their feet, slurring their speech, slow to respond, they kind of need to know a little bit of what to do next. So it's important to have them aware of withholding the alcohol, determining a plan, and knowing who to contact. What to do if severe withdrawal symptoms are present. Can they adjust their dose? Who would they call if they need to give another dose? As well, in the context of COVID-19, making sure the setup allows for physical distancing and requirements are maintained to assess the client for symptoms of COVID-19 as well. What to do if the client is positive for COVID-19 or starts to show symptoms, so having all that put into place as well. And considering regular check-ins about how the client feels the managed alcohol program is going, and what are their goals, any concerns that they have, any services that they are ready to be connected to. And then just looking at some care planning, so just things that need, other things to include is discussing harm reduction and client goals. So remember, we really want to make sure we're keep the client's needs at the back of our mind when we're planning to do this for the client. Determining doses and types of alcohol that you will be providing. Determining, again, the frequency, making sure you provide education to the clients as well when you're starting them on this program about what to expect, what it'll look like, and also what are your program's requirements or how it will actually look in play. There are a few other models. So there's also swap models to reduce harms related to non-beverage alcohol use. So in this example, service users who seek out non-beverage alcohol can swap out for alcohol. So for example, they may be able to bring in their non-beverage alcohol and receive 2 to 4 beers. So they can have 2 immediately and 2 for an hour later if they're not going to return right away. Better to do this than have them with a bottle of mouthwash. Staff should also adjust the doses of beverage alcohol if they see signs of non-beverage alcohol consumption. So this is something to be aware of as well, and make sure that there's protocols or staff know who to contact if they start to see this be a concern. And there's many different alcohol programs, including community day programs, residential models that can be located in shelters, transitional housing, as well as hospital-based programs as well. We'll touch base on what a hospital-based program will look like a little bit closer to the end. So proposed harm reduction strategies, basically when we're looking at just having a safe place. So a place where illicit drinkers would be protected from being victimized or any criminalization, having them have strong connections to other services such as detox and housings, and just peer-based services in which illicit drinkers would be the decision makers. And this is also seen as most likely going to meet the community's need. And just having a place where they are being provided with alcohol, so they're not outside in public or at the park, where they say if they are on the streets, alcohol can be stolen, they can be beaten up or injured just so someone else can take their alcohol. Now we'll look at a little bit of the managed alcohol program in Fraser Health. So food and housing is provided on site, mobile wound nurse is coming on site, as well as there's a social worker that comes on site. So the managed alcohol program in Fraser Health, it's in Surrey, it's at our Olive Branch shelter. There's a separate area for managed alcohol clients within the facility, and that's been able to help build connections between the participants. Doses do not need to be witnessed, but the managed alcohol nurses room is right next door to where the clients are. Sometimes they end up taking their alcohol outside, but it's a gated, fenced area, but they are encouraged to stay in the managed alcohol area. Their service delivery model. So again, an important aspect of a managed alcohol program is the ability to access appropriate social and cultural supports, and which will enhance the client's well-being. So in Surrey, we have Fraser Health staff on site from about 8 to 4. There's an LPN as well as a clinical support worker, and in the evening what they do is they leave enough alcohol for the shelter staff to administer. So the shelter staff don't have access to the big supply or the fridge. What the staff do during the day before they leave is calculate how much alcohol the client is most likely to need in the evening, and then they'll leave maybe a few extra just in case for the shelter staff to administer. The eligibility criteria. So right now, our managed alcohol program was open due to the risk of exposure and transmission of COVID-19. So in order to be on the managed alcohol program, you need to be at the Olive Branch shelter or in one of the isolation centers or the emergency response center. So you need to be in one of those facilities. You also need to be identified as high risk around use, so severe withdrawal, multiple hospital trips, injuries related to non-beverage alcohol use, or any other risks of looking at the patterns of drinking, non-beverage alcohol use, or alcohol or beverage alcohol, as well as binge drinking. The program in Surrey has a physician, so the physician will review the referral, take it up and discuss with the team, and then the physician accepts the client into the program and then would write orders. So this is just a sample sheet of what the physician orders look like. Most clients are either on vodka or beer. There's no one currently on cider, and they would just fill out how much the client can have throughout the day and then cap it off at a max. And then there are a few other things here, so staff know if any of these are present, they know who to contact. So again, this is just one of the sample orders. So if it's beer or vodka, the orders will look like 1 can once every hour for either 9 beers in 24-hour period, or max of 12 beers in a 24-hour period. Vodka, they do have the little shot glasses with 30 mils, so it'll be 1.5 ounces. So again, it'll be how many shots are they receiving of vodka in a 24-hour period. Again, earlier we talked about the cost of a hospital visit compared to a managed alcohol program. So kind of just putting that into a bit of perspective here. So the average cost of a beer pack is about $35.99. So this is from the Fraser Health staff, from the coordinator who is actually buying the alcohol. Again, pricing is dependent on where you go. He gets his from a local brewery. So let's look at a beer pack of 24 cans is about $35.99. So 1 can equals to being $1.45. Total for a patient, total for patient A for 6 days, the total is $30.61. The total for patient B for how many drinks he was having, total is $20.30. So now if we compare this to a hospital visit, which can cost $750, we're not even anywhere close to that with supplying alcohol to even 2 participants over a period of 6 days. So you can see that actually a managed alcohol program supplying alcohol definitely is a lot cheaper than the clients showing up in multiple times in the emergency room. This is just a nice little diagram the coordinator made at the managed alcohol program. So basically the shift starts, the staff want to do an inventory count, you assess the patient by using the clinical institutional withdrawal assessment tool, you do a set of vitals, make sure everything's okay, you'll do a wellness check, I'll show you those documents in just a moment. You either administer or withhold the liquor and the medication depending on what the last few assessments showed you. You still need to document on a medication administration record, and then you continue to do assessments and withhold or administer alcohol throughout the day, and then you just want to make sure you end the shift with another inventory count. This is just a sample of what the client agreement letter looks like. So knowing that if they're started because of COVID-19, that they're suspected they may be positive for COVID-19, they're requested to stay and self-isolate, and then they'll be educated on how managed alcohol will help them not need to go out into liquor stores. There'll be a discussion around how many times the staff are checking in with them. So again, this is already helping them connect to services because they know they're going to have interactions with staff throughout the day. So they're not going into withdrawal, or they know multiple times they're talking to staff, they're able to start building rapport and look at different options and connecting them to services. This is just looking at other tools to just confirm how severe someone's alcohol dependence is. This one's just another tool used to predict in advance someone's alcohol withdrawal severity. So this helps the physician know how much alcohol we may need to provide this client and what their current drinking patterns are and how much the managed alcohol program will need to be providing. This is a wellness check form, so this is important. This one will look at symptoms of COVID-19 as well as withdrawal and intoxication, and then just signing off whether alcohol is going to be provided or withheld. Again, we want to monitor intoxication, so there's another separate tool if staff would like to use to know how to score a patient's intoxication level. And this is, again, just another case study. So what we talked about earlier was a hospital visit is approximately $750. This participant in 2020 went to the hospital 57 times. His main reasons were intoxication, and the odd fall due to intoxication, averaging out 4 to 5 hospital visits a month. In 2021, then he got started on the managed alcohol program. So just looking at 2021, he's only had 4 hospital visits for intoxication and fall, again, due to being intoxicated, but we're already at an average of 1 hospital visit per month. So if we look at hospital visits in 2020, this participant cost for his ER visits was about $47,750. In 2021, it's been $3,000. However, let's just say the beer pack of 24 cans is $36. So in the 3 months, if he's had 6 beers a day, we're looking at spending about $9 a day on alcohol, and over 3 months, $810. So in 2021, the amount of managed alcohol money spent on this participant is $810 versus basic ER visit plus physician fees is looking at $3,000. So again, this really shows the benefits of a managed alcohol program, which include social connections, shelter, food, just checking in with staff, and really the impact it has on the healthcare system. So the earlier question that we want to look at is if a managed alcohol program was beneficial to the healthcare system. This goes to show that it is. Just quickly letting you know what happens in acute care. So in Fraser Health, we have patients that are able to come into an acute care setting that have been implemented to support patients with severe alcohol use disorder in the community. So really what this will help them do is prevent them from going into withdrawal or get them to not use non-beverage alcohol use while they're in acute care, or get them to stay for the duration of their treatment. Sorry about that. There are programs, again, where patients are going to acute care and able to receive managed alcohol, because beer and vodka are now on the BC formulary and can be dispensed by the pharmacy. So in summary, alcohol use can be the reason for people becoming homeless, a response to trauma, poverty, and difficult life circumstances, and also a way of coping with being homeless. Managed alcohol programs have offered regulated access to beverage alcohol alongside other health and social supports. Again, looking at a study based on 13 Canadian managed alcohol programs, 6 key elements were identified: goals and eligibility, food and accommodation, alcohol management and administration, funding and money management, primary care, as well as clinical monitoring. So benefits related to reduced hospital and policing costs, improved hygiene and nutrition, and increased medical compliance, as well as they're able to reduce the use of non-beverage alcohol, improve quality of life and safety, increase housing stability, and reduce demands and costs on the healthcare system. In long-term managed alcohol residents, they were less likely to use other illicit substances, steal, or go without alcohol, and they were able to more likely engage with services and treatment. This is just a quick guide that I wanted to just quickly show that if you're concerned about anyone's drinking patterns or yourself, especially in the time of COVID, consider making a plan for safer drinking. And these are some things to consider. So what we talked about earlier is making sure to actually know the amount of alcohol that's being consumed. So what is actually counted for as one drink. So one 750 ml bottle of spirits is actually 17.5 drinks. One can of beer of 8% is actually 1.5 drinks, not just one drink. And one bottle of 12% wine can actually be 5.5 drinks. So it's just important to know that and just making a bit of a safety plan. So either reducing how often you're drinking or the individual you're making the safety plan for, getting them to reduce how much they're drinking each time they're drinking, as well as maybe drinking to lower alcohol contents, are all things to consider. Thank you so much for joining me in my presentation.
Thank you so much, Simran. That was a wonderful presentation. It's really highlighted the incredible opportunities that we've had to expand MAP services to our clients who are certainly benefiting from the service. So we just had if there's anyone that's on the call today, if you have any questions about the presentation, you can just pop them into the chat and we'll read them out momentarily. I just wanted to clarify, in Fraser Health, where do the referrals come from?
The referrals can be made from the addiction assessment nurses at the hospital or the addiction medicine consult teams at the hospital, or I believe the intensive case management team. And we now also have a COVID-19 response with the emergency ERC shelters and the isolation shelters. So everyone's been kind of a little intertwined. And because clients from the managed alcohol program have been going, if they need to isolate to some of these centers, they'll kind of connect to see if a client is eligible to get started, or if the client would like to get started, they can inquire further.
Oh, that's wonderful. Is there a wait list for the service?
No, there's not. I shouldn't say no, there isn't necessarily a wait list. It's when you get referred, the physician needs to be able to review the case and make sure that the client is eligible, go through doing a complete assessment, and then going from there. So it may take a little bit of a time from the referral to actual getting doses of managed alcohol.
Wonderful. And then we had one question from the audience, just to clarify if it was physicians that are signing off on the orders.
So in Fraser Health, it is a physician that is signing off on the orders.
Wonderful. Is there any peer involvement in the service?
In Fraser Health, it's working out of the shelter, so we've got shelter workers there. As I mentioned earlier, there's a lot of in-reach being done. So we've got wound care nurses, social workers, and some of the other centers, isolation centers, there's peer involvement. But just with COVID right now, we're just in-reaching instead of getting them to outreach to connect to people.
Oh, it's wonderful. Well, thank you so much. That was really informative, and it's really exciting to hear about all the work that's going on in Fraser Health, and it'll be really exciting to hear in the future about all of the positive impacts that it's had on the community and for the clients. And yeah, it's exciting to hear that it may be something sustainable, even moving past COVID. Yeah, it's really great. So thank you so much for the presentation today. And thank you so much to the audience for joining us. Of course, if you have any questions, you can also reach out to Simran after the presentation and make a connection there. And hope everyone has a great day. Thank you so much for joining.
Thank you.
Bye for now.